Health. I'm Dr. Anthony Gonzalez. I'm your host for Miami Community Health. We have another important health topic to talk to you about today. We're going to talk about infertility. Infertility is unable to get pregnant, unable to bear children, unable to have a child. And I was in preparation for this meeting and this show. I was looking at some of the stats, and it's 17% of the adult population has infertility worldwide. 11% of women suffer from infertility, 9% of men. And today, around 19% of couples are unable to get pregnant. So it is really a common problem, and I didn't realize it was so common. So to talk about infertility, we have to bring an infertility expert. So I brought a friend and a colleague, Dr. Armando Hernandez-Rey, to talk to us today. Welcome.
Thanks, Tony, for the invitation.
All righty. So first, why don't we talk a little bit about you, what you do, what type of doctor and specialist are you?
Yeah, so the official title is a reproductive endocrinologist and fertility specialist. I'm an OBGYN at first, did a 4-year residency, and then in order to get board certified in infertility medicine, you have to do another 3 years of a subspecialty or a fellowship. And so board certified in both. And I've been in Miami in South Florida for now over 20 years, and born and raised here. So there's no place to be better to have come back.
Wow. So obviously you're trying to help these women and couples.
Yeah.
And we're going to talk about that. You help the men and the women.
We do. Yes.
Right? Is that right?
So, very comprehensive care.
Okay. And you help them try to get pregnant. And once they get pregnant, then you're done with them.
Yeah. We see them up to the first trimester. And then, at this stage of my life, most patients come to me from referrals, just like you, and establishing relationships with the local doctors. And so we refer them back to their OBGYN who referred them or whoever that person may be.
And have you seen in the last 20 years and 25 years that you've been involved in this, that the infertility treatments have changed?
Absolutely. I mean, more than anything, the change has been an addition to, augmenting what we've been doing and perfecting it, honing our craft a little bit with not only better medications, better protocols, and the addition of genetics and technology in the laboratory has been incredibly helpful to increase our pregnancy rates, 2, 3, and 4-fold from when I was a fellow.
Now, let's talk about infertility. Let's first just define what infertility is. Obviously, just trying to get pregnant for 1 month obviously is not infertility, right? So why don't we, for our audience, when should you start being worried? You got married, now you've already lived your beautiful married life, whatever the appropriate 5 years of before you have a child, and now you're trying to have kids. When, as a couple, are you starting to get worried that, hey, I have a problem with fertility?
So the traditional definition has always been if the woman is less than 35, then if you've been trying for a solid year, that's when you should seek out the help or the consultation of a reproductive endocrinologist. If you're over 35, which is designated as advanced maternal age, then that number should only be 6 months. However, that is a definition that's been in play for over 40 years, right? But the world that we live in today, and one of the major reasons why infertility has increased so much is because age is the biggest factor that's implemented in these increasing rates of infertility. Age is the biggest factor, the most important factor. And so I think while we still hold on to those definitions, I think not only have we become an instant gratification society, I think you focused on, or you mentioned that, whatever your timeline is for enjoying your married life, dinks, if you will, is been shortened because people are waiting longer. They're focusing on their careers. Women are now in the workplace at an equal pace than men. And unfortunately, the biology was not designed to give yourselves 3-5 years when you're 35 years old and are now just getting married for the first time because you focused on that career.
Now, we talked about age 35. When is it really not feasible to get pregnant? When should you start thinking about, hey, it's probably not feasible?
Well, that's a there's a lot to unpack there. There's a lot of other things that we need to consider. In general, pregnancy rates plummet precipitously after the age of 37, certainly after the age of 41, and absolutely after the age of 43. And those are the things that, everybody gets lulled into a false sense of security, regardless of how sophisticated and educated you are, because everybody has one or two people that they know that got pregnant on their own after 45, but that you only know one or two people. And number one, and then the other very key factor in this is that there is no person, no couple that ever said, you know what, when I get married to my Prince Charming or the woman of my dreams, I'm going to go to Hernandez-Rey or some other colleague of mine to go start a family. And so people are like fully entrenched in trying on their own. And unfortunately, whether it's something underlying or just psychologic, it takes them a little bit of time to get to that place to say, listen, I need help.
All right. So before somebody has to seek an opinion from you as an expert and a specialist, are there simple things they should be trying, before that? I remember, temperature, remind me some of that, maybe temperature.
Yeah, the basal body temperature, that's
right.
Less accurate. Now there's some incredible apps that are available on the market.
So talk about some of the simple things people should try, like in those first 6 years to a month, to maybe increase their chances of pregnancy.
So number one is focusing on your menstrual cycle, on the woman's menstrual cycle. That's first. Number two, adding to that or piggybacking off of that menstrual cycle and the regularity of the menstrual cycle, which should be anywhere between 25 to 35 days. Anything outside of those margins should be looked at, but also tracking the ovulation. In general, a woman who has a cycle that's greater than 35 days, that is an anovulatory cycle. So a cycle that where she is not ovulating, at least where the time frame where she should, or at all. And so you can have sex every single day of the week and it's not going to happen. And so adding to that cycle monitoring with apps or just with a calendar is ovulation kits, which are simple to obtain at your local CVS or Walgreens, even online, and monitoring that ovulation. And when that peak happens, and then that's where intercourse should happen, timed intercourse should happen the days following that peak surge, which is what tells you not that you're ovulating, but that you will ovulate within the next 24 to 36 hours.
So it's all based on calendars and timing.
Correct. And basal body temperature certainly helps. It's a little bit more difficult to track. It's a little bit of insensitive. A lot of people tell me, I'm supposed to check it before I touch my feet touch the ground.
Yeah, I remember that.
And yet people like wake up and they've gone to the restroom and they go, geez, I missed it. Right. So ovulation kits are key. They're very sensitive. They do have their false positives and their false negatives, but for sure, it's a good place to start.
All right. So somebody tries all that and they've tried to get pregnant. They tried these ovulation kits and it's been 6 months or a year. They can't get pregnant. And now they go see you. Mm-hmm. What is that evaluation like? What happens in that evaluation?
Actually a lot happens. As you know, women are much more complex than us men will be. I always say we're like amoebas. One simple semen analysis and we know of a man is fertile, subfertile, or infertile. Women, there's a constellation of testing that we need to do. Number one, and most importantly, and definitively associated with their age, is their ovarian reserve. As you know, women are born with a finite number of eggs, and the consumption of those eggs essentially is what transitions a woman from puberty to eventual menopause. And in general, that is probably about 32 to 35 years. So from the average age of menarche, or the first period, is about 12 and a half years old, to about the 43 to 44 threshold or ceiling on that reproductive aging. And then following that is to look at the pelvic architecture, the fallopian tubes, the anatomy, the uterus itself, and the patency of the fallopian tubes, and the juxtaposition, if you will, of the fallopian tube to the ovary itself, so that the tube is able to capture that egg when it's extruded or ovulated. And then ovulation. Is a woman ovulating? We check that with what's called a mid-luteal progesterone, which is generally anywhere between 7 and 9 days after that ovulatory surge. You should see a spike in your progesterone, which is what maintains the pregnancy until the placenta has taken over. And then, a myriad of other testing that include both endocrine testing, like the thyroid and the prolactin levels, which are extremely important in women primarily, with hypothyroidism or thyroid disease being the primary endocrine disorder that affects reproductive age women.
Now, in your practice and nationally, do we see infertility mostly attributed to men or to women? Who's at fault here most of the time?
Interesting question. So women are always going to be more quote unquote responsible. I mean, I always say this is a team sport, so it's not about me or about you. It's about getting the job done. But what's interesting is that over the last 20 years or so, we've seen an incredible increase in the responsibility of the male as a contributor to the infertility for the couple itself. It used to be that it was 10 or 15%. Now we're seeing numbers of 30 to 35% implication, whether it's because of radiation, ambient radiation, whether it's your cell phone, and this is really a legitimate concern. Cell phones in your pocket, alcohol intake, aging, which I mentioned is important not only for the female but for the male as well, with advanced maternal age, and the consumption of, for example, cannabis. People say that when our parents, the Woodstock age of cannabis didn't really affect, but what people don't take into consideration now is that the potency of the THC that people are consuming is 10 to 12% higher. 10 to 12 times higher. Wow. And augmented even more with the vape pens that are available. And so that has a significant impact on fragmentation and sperm counts in general and quality.
And so today it's probably 30%?
30 to 35%, and we're seeing it's not going down or plateauing.
Wow. Okay. And for the male evaluation, it's just to check their semen. Is that
semen analysis and the 5 basic parameters, which are the concentration, the volume of the semen, which is the vehicle in which sperm travels, and then you have the concentration, which is the total number of sperm, dead or alive, in 1 milliliter of the semen, and things like motility, how they move. Sometimes they're dead, and you have like something called necrospermia. Morphology, the shape of the sperm, which can be altered with any exposure to toxins, and the total motile number of sperm, which is probably the most important number because we're looking at just the sperm that are dead or that are alive, which are the most important ones.
Right. Now let's talk a little bit about lifestyle. How does lifestyle impact fertility and infertility? Smoking, obesity, alcohol, drugs, sleep, rest. Talk to me about that.
You've just mentioned something that is so important, and things that we usually took for granted. I've really now incorporated a lot of the longevity principles into the care of my patients because they make so much sense, and you're talking about the obvious ones: obesity, diabetes, hypertension, the comorbidities that we talk about, drinking, obviously, and smoking. Those are things we've known for years, and finally are have enough data to back it up and say, guys, this is really important. But we're talking about even beyond that. We're talking about endocrine disruptors that are found in just the bottled water industry. You have the leaking of the plastics and the BPAs and the phthalates that are extremely important, have tremendous effects. We do a test, an adjunct test to semen analysis in guys our age, advanced maternal age, who are having second families and even third families with younger women, and we're seeing what's called fragmentation testing. We're doing fragmentation testing, and we now know fragmentation testing is basically to assess the fragmentation of the DNA of the sperm, and we're seeing very strong correlations with cardiovascular disease and calcium CT scores and plaque buildup in the coronaries. So whatever's building up in the testicular vessels or vasculature is exactly what's happening at the level of the coronary and at the level of the brain. So it's all intertwined.
Yeah. It's your whole body is being affected. It's not only your heart.
Correct. And we'll go one step further. Even the gut microbiome, is like our second brain, and it's having a tremendous effect on everything, including fertility for both men and women.
All right, so let's talk a little bit about treatment. And obviously, I would imagine treatment is very complex because it depends on what the man or the woman needs. I guess let's start with the simpler one. A man, what is the treatment for men infertility? Obviously, just overall, what are some of the possibilities? Obviously, it depends if they have sperm, they don't have sperm,
correct,
and so forth. If they can even ejaculate and so
sure.
forth. So what's some of the treatment options for men?
We first start off with the basic semen analysis, and that's very telling of what we're dealing with. And you can have a pre-testicular, a testicular, and a post-testicular. Pre-testicular is something in the brain, whether they're working out or doing things that can affect the hypothalamus and the pituitary, and it's usually that's endocrine derived or exogenously derived. Maybe they're taking some sort of medication or testosterone that could affect the stimulation from the brain, and so we try to correct that, and that's very common in South Florida. People are working out, looking out for their muscles and their shape and their vein, and a lot of these guys, these young men, start off very early with the use of exogenous testosterone to build muscle mass. And what we know now is that over time, not only does it become like a drug, like you need this and you can't get off of it, but it atrophies the testicle to a point where it no longer has lost the capacity to produce sperm.
Wow.
And sometimes in very severe cases that can be irreversible, and donor sperm is the only option. Obstructive, if it's guys again our age who have had vasectomies and now are looking to have second families, well, we have to go directly to the testicle, and that can be in the way of a PISA, which is a PISA or a TISA, which is to go to the epididymis and extract sperm, or directly to the testicle and extract sperm that way. And then finally, something that affects a testicle in terms of atrophy or other things that we manage, medically and not surgically. And in terms of the surgical aspects is, varicocelectomies are also a big problem, especially as men get older, because they're doing weights, because of the Valsalva maneuvers. And so that has a significant impact when corrected on sperm production and quality.
Oh, wow. Yeah. Okay. And then let's move on to the women, which obviously the problem is more common in women. And let's talk about some of the treatment options and go through, whether you start with medication, I would imagine, if that's appropriate. And then let's talk about all this in vitro fertilization and so forth.
Well,
so we can understand the whole picture.
Obviously, depending on the situation, 30 years ago, 40 years ago, IVF results were very poor. And so we basically focused on ovulation induction with or without artificial insemination. And people are always intent, and I think less so now, but people are always intent on doing it the most natural way. And I totally get that. I completely understand that. So after we do an evaluation, and I alluded to the hysterosalpingogram as a means of identifying or evaluating the architecture of the female pelvis. And I don't need to tell you that endometriosis is has such a significant impact on that very thing. And not only altering the anatomy, but also infertility and inflammation and everything else that goes into the process of conception. So if it's surgical, one of the things that I'm very proud of is that as an old guy, I still love surgery. I was your medical student and interning with you when I was thinking about general surgery. I've always been very surgically inclined. And so I think it's part of the comprehensive care that I like to offer, instead of referring out to somebody else that may not be in tune with the comprehensive care of that patient. So anyway, if she needs surgery, whether it's corrective surgery for tubal disease or endometriosis, in collaboration with somebody in your team or one of the GYN oncologists, et cetera, we focus on that first. And then in terms of the overall treatments that people are very familiar with is first ovulation induction, which is to give a woman a pill, an injection, or a combination of the two to get them to either ovulate because they're not ovulating. And that's very common in something called polycystic ovarian syndrome. Mm-hmm. And then incorporate either timed intercourse, depending on the age of the couple, or the male factor that may be involved, or just go straight directly to to artificial insemination to assist and make the couple as a whole more efficient. Mm. And then finally, in vitro fertilization. The couple is beyond, depending on age, depending on the results of their testing, whether there's a very severe male factor or just diminished ovarian reserve or premature ovarian insufficiency, as now is the new term du jour. Then we may need to embark on more aggressive therapy, and that's in the way of in vitro fertilization. Also depends on the age of the couple, right? If they're looking for their first kid, and she's 40, and it's most couples want more than one kid, and so while we still want to do the more natural approach, we need to be.
You don't have the time.
you don't have the time. And so what in vitro fertilization offers you a couple of things. Number one, and I'm not selling on, I'm just giving you the benefits of it. When you get into that, you're thrust into that position for whatever reason, which is that it's the most efficient way to conceive, number one. So you're not leaving it up to chance. Number two, you're able to do genetic testing. And that's one of the biggest obstacles to actually having a live birth, which is the genetic aberrations that occur after the age of 35 and certainly after the age of 37 in both men and in women. And finally, the only way that we have of freezing a couple's fertility in time, somebody's 40, doesn't have children, you need to consider that if you are fine with one, okay, well, maybe we can, pump the brakes on the aggressive factor. But if you want more than one, and most people do, and even the ones that tell me they swear they only want one, they have selective amnesia once they have that kid in their arms, and they want a second one for sure.
So overall, somebody comes to your office. What is this chance of success overall, without you even beginning to evaluate them? Of course, as you begin the process and you start seeing how bad the problems are or how bad they're not, you're gonna kind of give them a better chance. But overall, when somebody comes to your office, what is the chance of success?
Depends on what it's a very complex question, honestly, and I'm sure you can appreciate this because there's so many variables in place, right? It's all somebody who comes in and they're 40 years old versus somebody who comes in 30, well, your chances are cut in half just because of their age. I'll give you an anecdote. And it's somebody that I just saw recently. This is a patient who was 39. On paper, everything looked fantastic. Her husband's 2 years older when they came to see me, 41. Both attorneys, both wanted a lot of kids, went directly to IVF. To batch embryos or bank embryos or, because of that, what we just talked about. They did 3 cycles. They had a total of 38 eggs, 26 eventually fertilized, and eventually, which is incredible, extraordinary for that age, we had 18 embryos that we were able to do genetic testing on to assess for any normalcy, euploid versus aneuploid, which is the scientific or genetic term for it. Well, of the 18 embryos that we were able to biopsy, only 3 were normal.
Wow.
They now have 3 beautiful children, and so we were 3 for 3 in that regard. And that does not always happen that way. It happened to thankfully happen for them, but that is the attrition that you see with the aging process. And everything on paper was fine.
Now let's talk a little bit quickly about the freezing, because we see a lot of that, and we see it also in cancer treatment.
Sure,
women with breast cancer treatment got to go undergo chemotherapy and so forth. Freezing, is it safe? Can it be done? Both sides, male, female?
That all falls under the fertility preservation sort of pillar of our practice, and it began with the oncologic population, and it took us a long time to convince the oncologist to say, listen, cancer treatment is more successful than it's ever been. You can give me a window in order to preserve their fertility, because these women and these men are outliving this therapy, and they should have other aspects of their life. I mean, my God, they've outlived cancer. Yeah. They should be able to go on and live a productive life and start their families. And so it took us a long time, but I think we're there, and we see quite a number of patients from the local cancer centers. But then beyond that, once it was not considered experimental, it started off with women and freezing eggs. We still have a long way to go, but it's the best thing we have available. The limitation of freezing eggs for women is that we can't stick a probe in it and go and say it's a good egg or bad egg. And going back to the example I just gave you, we had 38 eggs. Eventually, there was only 3 normal embryos. Wow. So depending on on a woman's age, numbers matter. And so if you're 30, well, we need less. Ironically, that's when we get the most eggs. And when you're 40,
more.
Right. When you're 40 and when you need the most number of eggs is when we get the least. So sometimes.
And you can keep those eggs long term. They're good
in perpetuity. Yes, okay. For sure.
They're good. They don't go bad after a couple of years, even with freezing. Or
no, the technology is so robust right now. It's called vitrification, as opposed to what we used to do before 15 years ago, called the slow freeze protocol. Now, these eggs, if it's a good egg, it will survive the thaw for sure.
And the sperm can be banked as well.
Yeah,
long term as well.
Yeah, that we figured out. Like I said, we're amoebas,
It's simple for the men.
Simple for the men, and we're wildly successful at freezing sperm, whether it's cancer therapy, prior to cancer therapy, because of aging, and even prior to a vasectomy.
Right. So obviously, as we close here, very complex problem. That's what I'm understanding. I'm understanding that age is very, very important.
That's
okay? Right. And obviously, probably 35% is caused by a man, the rest by a woman. But, sometimes this could be very costly, may not be covered by insurance, and people seek outside evaluations, outside help. So, and I see that in my world, like in bariatric surgery and everything else, that people go elsewhere for infertility treatment and so forth. So talk to us a little bit about that infertility tourism and people going elsewhere versus, a program like yours, which is obviously in the U.S. and a very robust program. How can that be different?
There's like in your world, there's the appeal, the financial, the appeal is there, and the financial obstacles that are, that are here in the United States are different than outside. However, like in terms of in my world where the technology is ever evolving, and you need to keep up with that, it's more expensive in the United States for a reason. Putting live air into our laboratories is very expensive, but then you have patients who go elsewhere. They do 3 or 4 cycles of IVF or anything else. They've lost money on travel time away from work. They do end up doing 3 or 4 cycles, and they come here not just to me, but to a well reputed practice here in the United States. And while they may have saved on the front end, they end up losing a lot on the back end because they then come back here and have to leverage everything they have because they really are intent on having a family, and then they get pregnant on the first try. And then, it's a difficult situation. I don't blame them. But you have to understand what you're getting yourself into. The oversight that we have here in the United States with SART, ASRM, the CDC, the FDA is like nowhere else in the world.
No doubt about it. All right. So as we close, any parting recommendations for those families out there that want to have kids or thinking about having kids, maybe got recently married and they're, in the future? Any pieces of advice? I've heard healthy lifestyle versus very, very important. Probably have the kids a little younger. Right? Because you have a higher chance.
Or preserve your fertility.
Preserve your fertility.
Yeah. Whether it's embryo cryopreservation or freezing if you're married and just like, listen, I really want to.
Even if you're not going to need them, right?
Right. You can just keep them.
Just keep them just in case.
And we're seeing that more and more. And anyway, but listen, I guess the take home here is don't get lulled into a false sense of security because you think you're healthy, because the two are not mutually inclusive, they're mutually exclusive events. Wow. And so seek the care of your OBGYN, get an anti-Mullerian hormone, semen analysis, make sure you're ovulating, and take care of yourself.
Wow. Perfect. That's what I always say. Take care of yourself. Take care of yourself and your family. Armando, thanks for coming.
Thanks for the invite, Tony.
No, thank you. Thank you for the information. Another great show. Another bunch of information for you. Learning about infertility, how it impacts you, and what the treatment options are. I want to thank Dr. Armando Hernandez-Rey and obviously his center for educating us today. And once again, Dr. Anthony Gonzalez with Miami Community Health, reminding you to take care of yourself and your family.